Abortion refers to the termination of a pregnancy before the birth of the child. This is usually performed before the limit of fetal viability. In Singapore, abortion is allowed up to 24 weeks of gestation. According to the World Health Organization, between 2015 and 2019 on average, 73.3 million induced abortions occurred worldwide each year. Estimates from 2010 to 2014 show that around 45% of all abortions were unsafe. Almost all of these unsafe abortions took place in developing countries. Each year, between 4.7% to 13.2% of maternal deaths can be attributed to unsafe abortions. Termination of Pregnancy Act. Singapore's laws on abortion are encapsulated in the Termination of Pregnancy Act of 1974, which is as follows. This Act states that every treatment for terminating pregnancy shall be carried out by an authorized medical practitioner in an approved institution. Unless it is immediately necessary to save the life of the pregnant woman, termination of pregnancy can only be carried out for A. A citizen of Singapore or the wife of a citizen of Singapore. B. A holder or the wife of a holder of a work permit pass or employment pass. Or C. A person who has been resident in Singapore for at least 4 months. No treatment for terminating a pregnancy of more than 24 weeks can be carried out unless the treatment is immediately necessary to save the life or to prevent grave permanent injury to the physical or mental health of the pregnant woman. Pre-abortion counselling must be provided for a pregnant woman regardless of her marital status. The Act requires the pregnant woman to sign a declaration that she has been counselled, and there is a mandatory waiting period of 48 hours after the counselling before the procedure can be done. Special groups include girls below 16 years of age, except for rape victims. It is mandatory to refer an unmarried girl below 16 years of age for pre-abortion counselling at the Health Promotion Board Counselling Centre when she seeks termination of pregnancy. A certificate of attendance will be issued to her by the centre. No termination of pregnancy can be performed unless the certificate of attendance is produced by the girl. Mentally disabled women require certification by a psychiatrist that continuation of the pregnancy will be harmful to the mother before medical procedures can be done. Indications for abortion. There are different indications for abortion which can be categorized into maternal, fetal, and social factors. Pre-abortion considerations. History and examination. A full medical history including parity, previous surgeries and abortions, any complications during previous abortion must be taken. A thorough examination must also be conducted, in particular to assess uterine size to correlate to gestation, and any adnexal tenderness or masses. Gestational dating. The use of the woman's last menstrual period should be confirmed by pelvic examination of the uterine size. Pregnancy location, viability and gestation must be confirmed by a pelvic ultrasound examination. Other investigations to carry out include full blood count to assess hemoglobin, rhesus status, chlamydia screening, and beta-HCG in first trimester medical abortions. Counselling. Preoperative counselling includes a thorough discussion of the various types of termination procedures, medical or surgical, and includes the risks, benefits, and expected outcome of each procedure. Alternatives such as continuation of pregnancy and adoption must be discussed as well. Contraceptive options should also be discussed. For example, the woman may choose to have the intrauterine contraceptive device or implant inserted after a surgical abortion under anesthesia. A signed informed consent should be obtained from all women. Infective prophylaxis. Universal antibiotic prophylaxis at the time of abortion reduces the risk of subsequent infective morbidity by up to 50% and decreases post-abortal infection in surgical abortions. Thus, routine antibiotic prophylaxis should be given. Antibiotics effective against chlamydia trachomatis and anaerobes should be considered. The following regimens may be considered for surgical abortions. Azithromycin 1 gram orally on the day of abortion plus metronidazole 1 gram rectally, or 800 milligrams orally prior to or at the time of abortion, or doxycycline 100 milligrams orally twice daily for 7 days starting on the day of the abortion, plus metronidazole 1 gram rectally or 800 milligrams orally prior to or at the time of the abortion, or metronidazole 1 gram rectally or 800 milligrams orally prior to or at the time of abortion for women who have tested negative for chlamydia trachomatis infection. Options for termination. There are 2 types of pregnancy termination procedures: medical and surgical methods. The type of abortion chosen depends on gestation, operator experience or preference, availability of resources, and the woman's fitness for surgery and her preference. Surgical abortion has the attendant risks of anesthesia and surgery, but can be completed in one visit. Medical abortion avoids the risks of surgery and anesthesia, but the woman may experience prolonged bleeding as well as side effects of the medication. For termination of pregnancy in the first trimester, the medical method includes either a mifepristone misoprostol combined regimen or misoprostol only dose. A combined regimen of mifepristone and misoprostol used up to 10 weeks gestation is universally recommended as it is more effective than misoprostol alone. Mifepristone RU486. Mifepristone is an antiprogesterone which increases sensitivity to prostaglandin 24 to 48 hours after its administration. The combined effect of mifepristone and misoprostol permits greater efficacy of prostaglandin at lower doses, thus minimizing potential side effects. Contraindication for this medical method includes porphyria, chronic adrenal failure, on concurrent long-term corticosteroid therapy, or women who are at risk of hemorrhage. Misoprostol is a synthetic prostaglandin E1 analog. It is generally well tolerated, inexpensive, can be stored at room temperature, and is widely available. Misoprostol can be administered via vaginal, oral, sublingual, buccal, or rectal routes. Up to 10 weeks gestation, the recommended regimen is 200 milligrams of oral mifepristone followed 24 hours later by 800 micrograms of oral or buccal misoprostol. Side effects include nausea, diarrhea, and fever, which are self-limiting. Asthma is not a contraindication to use misoprostol. At less than 8 weeks gestation, vaginal misoprostol with initial dose of 800 micrograms followed by 400 micrograms every 3 hours up to 3 doses has high success rates. After medical abortion, the woman is reviewed 7 to 10 days later with a repeat beta-HCG. In a successful abortion, beta-HCG levels drop by close to 80 to 90%. The woman can be reviewed in 6 to 8 weeks to assess for return of menses. If the drop in beta-HCG levels is suboptimal, a repeat dose of 800 micrograms may be given and beta-HCG evaluated in 1 week's time. The surgical method is also known as vacuum aspiration. Surgical vacuum aspiration is best performed between 7 and 12 weeks. Surgical aspirations performed at less than 7 weeks gestation are 3 times more likely to fail than those performed between 7 and 12 weeks. This is an appropriate method at early gestation only when there are safeguards to ensure complete abortion. These safeguards include confirmation of products of conception at aspiration by placing products of conception in sterile water or saline to wash away the blood and look for fetal membranes or fronds of chorionic villi, or ultrasound confirmation of a complete evacuation after the procedure by assessing the endometrial cavity and endometrial thickness. Cervical priming is beneficial where difficulty in cervical dilatation is expected, especially in nulliparous women. Adequate cervical preparation can help minimize the occurrence of procedure-related complications such as cervical laceration and uterine perforation. Cervical priming methods include pharmacological agents, example misoprostol. Both oral and vaginal misoprostol given at dosages of 400 microgram are effective for cervical priming when administered 3 hours prior to surgical vacuum aspiration. Rigid dilators, for example, Hager dilators, can also be used. For termination of pregnancy in the second trimester, the medical method includes either a misoprostol-only regimen, mifepristone misoprostol combined regimen, or intraamniotic instillation of abortifacients. For misoprostol-only regimen, 400 micrograms of misoprostol is administered vaginally every 3 hours for up to 5 doses. Vaginal administration of misoprostol-only regimen was shown to be more effective and associated with a shorter induction to delivery interval compared with oral administration. For mifepristone misoprostol combined regimen, 200 milligrams of mifepristone is taken orally, followed 36 to 48 hours later by 800 micrograms of misoprostol vaginally, then 400 micrograms of misoprostol orally or vaginally every 3 hours to a maximum of 4 further doses. Lastly, for intraamniotic instillation of abortifacients, example prostaglandin F2 alpha and hypertonic saline. Hysterectomy or hysterectomy may be considered after failed medical abortion when dilatation and evacuation cannot be safely performed, such as in situations where multiple obstructing myomas are present, with pelvis peritoneal malignancy, or after an abdominal circlage. The surgical method of pregnancy termination in the second trimester is a procedure known as dilatation and evacuation. The procedure must only be performed by an experienced operator with adequate cervical preparation. A vacuum cannula can be used, although forceps may be required at later gestations. Post-operative care. Women should be observed for vaginal hemorrhage or changes in vital signs for at least 4 hours before discharge. Women who are Rhd negative and unsensitized should receive anti-DIgG within 72 hours following surgical or medical abortion. After surgical abortion, women may experience mild lower abdominal cramps 2 to 4 days after the procedure, which can be treated with non-steroidal anti-inflammatory drugs. They may have light vaginal bleeding up to a week after the procedure. All women should receive a 24-hour contact number in case of emergency and should be advised to seek medical consult immediately if she experiences heavy bleeding, fever, or abdominal pain. Refrain from vaginal intercourse or tampon use 2 weeks post-procedure to reduce the risk of infection. The woman's chosen contraceptive should be started immediately. Intrauterine contraceptives or implants can be inserted immediately following medical and surgical abortion at all gestations, as long as it is reasonably certain that the woman is not still pregnant. Women who have yet to decide on contraception should be offered information on contraceptive options. Complications of pregnancy termination. Mortality rates of pregnancy termination is less than 0.1 per 1,000 cases, with a complication rate of 1 to 2 per 1,000. Complications of abortions increases with gestational age and in teenage pregnancies. Some of the immediate complications of abortions include trauma or surgery-related issues, risk of major hemorrhage, which increases beyond 20 weeks gestation, infection risk, retained products of conception, venous thromboembolism, and failed abortion. Carrying on pregnancy after misoprostol use has been associated with the development of multiple congenital abnormalities. Other complications that may arise include uterine rupture during subsequent pregnancy, cervical incompetence, infections like pelvic inflammatory disease, intrauterine adhesions or Asherman's syndrome, psychological sequelae, and slightly higher rate of retained placenta. Follow-up after pregnancy termination. After pregnancy termination, an immediate follow-up should be made within 1 to 2 weeks, where you assess for retained products of conception if there is prolonged or heavy bleeding, fever and abdominal pain, and endometritis with symptoms including foul-smelling discharge, fever, and uterine tenderness. Contraceptive advice should be given if she has not started on any method. At the delayed follow-up after 6 to 8 weeks, return of her menstruation should be checked. Prolonged bleeding after 2 weeks indicates a possibility of retained products of conception or endometritis. Signs of retained products of conception include an open cervical os, products of conception seen at cervical os or in the vaginal canal, thickened endometrial lining on pelvic ultrasound. If endometrium is thin, then consider treating with antibiotics for endometritis. If there is no return of menstruation, do a urine pregnancy test. If not pregnant, the woman should be reviewed again in 1 month. If she still has no menses 1 month later, combined contraceptive pills should be started for 1 cycle. If there is no response, then Asherman's syndrome must be excluded. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.